I just want to show you something back in arrhythmias real quick. So I had to remove this question from the last test, after realizing I didn't discuss it, only because the textbook didn't mention SVT.
No, he removed it. No, he removed it from the test.
If you listen to what I'm saying,
Yeah, so you don't count it. He didn't count it.
okay,
He didn't count it.
please pay attention.
So it'll be on our final?
Maybe.
Okay.
Now, when you have SVT or some other tachydysrhythmia, heart rates 180 or higher, the only FDA approved drug to terminate that rhythm is adenosine. Now, it requires a special way of administration because the drug has a very short half-life, literally a few seconds. About 10 seconds is the drug's half-life. So you need to give it really fast. And because it's 6 milligram, it's a tiny vial. So it's a 1 ml vial. Each vial is 6 milligrams. So the initial dose is 6 milligrams, but you can give another one if it doesn't work. So this will terminate SVT, and this can also be used for some instances. Some doctors use it for new onset AFib, but most people who receive it is SVT. And you can go into your patients can go into SVT just like this. So you need to know what the doctor needs when you administer this. So this is part of the crash cart, but since the patient here is still awake, now don't open the crash cart because this drug is also available in your floor stock. Because once you open the crash cart, it bills the hospital. No, because it's just a lot of bureaucracy. That's what I'm trying to say. I mean, you only open the crash cart if it's really, the patient's coding. If the only drug you need is adenosine, don't grab it from the crash cart. Grab it from the Omnicell or Pyxis, whatever your medication dispensing system is. So the way the drug works is, imagine it's 10 seconds half-life. So you literally have to push it within over 1 to 2 seconds and then flush it with 20 ml. Now, the reason for the 20 ml flush, and do we have 20 ml flushes or 10 mLs? We have only 10 mLs. So imagine how fast you'll have to do it. If you, let's say, even if the drug's already in a 2 ml syringe, 3 ml syringe, so you already have the adenosine drawn up. So to connect it to a clave port, the IV, to connect it, imagine the time, okay, how many seconds it's gonna take you. So granting you've already cleaned it, you insert the syringe, push it over 1 to 2 seconds really quick, and then disconnect that syringe, connect another 10 ml syringe, push it real fast, disconnect that, and then connect a second 10 ml syringe. Is that gonna take under 10 seconds? No. So by the time it took you to do that, is the drug still viable? No more. So you need the drug into the heart within less than 10 seconds, because 10 seconds, the drug's gone. Do you understand? Okay, so let me just show you a short video on how to do it. Don't worry, the doctors will do this, but since you're the ones that will be assisting the physician, okay, so this is the three-way stopcock that you'll need. Right? So you saw the patient is in SVT, right? Let me go back here to the beginning. So you saw the heart rate. What was the heart rate on this patient? Okay, 170 is correct. All right, so this patient is in SVT. That's what SVT looks like. It looks like sinus tach, but the rate is way too fast. And do you still see P waves? No more. So that is SVT. So again, the only FDA approved drug to terminate this rhythm is adenosine. Now, what's going to happen is when you give the drug, it's going to stop the heartbeat. You'll stop for probably 1 to 2 seconds. That doesn't mean the patient's dead. The heart just restarts. Okay, so keep an eye on the screen and watch what happens as they give the drug. So the drug is drawn up. That's the tiny 1 ml vial. So that is 6 milligrams. So that will be the first dose. Okay, so we attach a 10 ml syringe on a 3-way stopcock allows you to attach up to 3 syringes. That's why we call it a 3-way stopcock. And this is the switch that you can open and close whichever one because you can only open one port at a time. So you simply attach it to the clay port. So this is the the IV where you attach your syringe. Okay. So that's the 10 ml syringe here. And then you attach so this one here is the adenosine. Okay.
Okay, we've got our adenosine and our flush. Let's turn this so that all ports are open.
Okay.
And when I go ahead and push down, I'm gonna keep pressure on the plungers so that it doesn't back up.
Yeah, so keep pressure here because as she pushes here really fast, it's gonna go in there if you don't apply pressure here. So you need the adenosine to go in and then this one will follow right through. Okay, this is the only way we can give adenosine because if you don't use a 3-way stopcock, you lose time and then the drug is useless, right?
All right, everybody ready? Ready. Okay, we're gonna push the adenosine first, immediately followed by the,
By the way, this is in a controlled environment, meaning the crash cart is at the bedside because what if because we know the heartbeat will stop, all right, for about 1 to 2 seconds. What if it doesn't come back? All right, so we need the crash cart, okay? If I mean, that's never happened before, but just in case, yeah.
NS flush. 1, 2, 3.
Okay, flush real fast, 1 to 2 seconds, followed by the really fast 20 ml syringe. So that takes the drug straight into the heart, right? So that's 10 ml. So that will reach because you notice the IV was here, correct? So it's very close to the heart. So it'll go straight to the heart tissue. Look at the heart rate. See the pause right here? So the heartbeat stopped, right? Okay, so that's completely normal. Okay, that's expected to happen, but just make sure it comes back, right? There, see the heartbeat stopped and then it returned. All right, look at the heartbeat. Yeah, look at the rhythm right after it stopped. Back to sinus. See? All right. See the heart rate dropped immediately. Okay, so this is the expected. So about 8. Right. Okay. So that's adenosine. Right. So you saw how it's given. So if you get a question on it on the NCLEX, that's the sequence of events, and that's what's gonna happen. All right. So what happens to the heartbeat again?
Stop.
It'll stop. Okay, for only a couple seconds. Okay, maybe 2, 3 seconds, and then the heartbeat resumes. As you saw, it went back straight to sinus. Right. Okay. Of course, it doesn't always happen like that. Sometimes the drug messes up the whole rhythm, and that's why we need the crash cart. Okay, in those few instances that doesn't happen, or a patient may go into a systole and then and doesn't come back. So we need chest compressions and then ACLS. All right. The other one is on the TPN. The TPN tubings, should they be changed daily? TPN. total parenteral nutrition, should they be changed? Okay, only 24 hours. Okay, just want to make it clear. And let's say you're late and I gave you a scenario on that on the last test. So let's say it's late. What can you do? No, the bag is supposed to finish in 24 hours. Still half full. Okay, when you started the shift, oh, and then you have 8 hours left to finish like 1,000 ml left in the bag. So what do? The patient won't get their nutrition. Can I increase the rate? Okay, so your textbook clearly said should not be increased or stopped immediately. All right. Okay, just making sure you're aware of that. So in those instances, because they can happen, like things happen, patient got crazy or whatever happened, that the therapy was interrupted or slowed down for whatever reason. You can't make it up. Okay, don't try to catch up because that will create a massive osmotic pressure change, and then the patient will have some rapid fluid shifts, rapid hyperglycemia. All right, so if we miss the nutrition, there's nothing we can do about it. Okay, just make sure it doesn't happen again. All right, you can't catch up. There's no way you can't increase the rate. And I mean, we can't help it, but try to keep the schedule intact as much as possible. All right, let's go to ear disorders now. Let's start with, you see how we started with vision loss first? We talked about presbyopia, right? Okay, so now let's start with presbycusis. With hearing loss, there are two types of hearing loss here. We've got presbycusis, which is age-related hearing loss. You just got old, can't hear well anymore. There are also conductive hearing loss, and there's also sensory hearing loss, or you can have a combination of both, conductive and sensory neural hearing loss. When we say conductive hearing loss, that's usually caused by obstruction. How do we hear? How do we hear? Like, how are you hearing me right now? How does my voice reach you? Yeah, so how does sound travel again? Through waves, right? Yeah, so sound waves travel through the air and then they vibrate, and then as the structures in your middle and inner ear vibrate in response to those waves, then it is interpreted, right, by the auditory nerve. Right? No, it's transmitted by your auditory nerve to your brain, and then you interpret what you're hearing and understanding what I'm saying, correct? All right, so that's so therefore, if there's a conduction problem, so let's say there's too much earwax in your ear, or there's a bug stuck in your ear somewhere. Have you ever had that happen?
So.
Yeah. Yeah, I had a bug stuck in my ear once when I was a kid and couldn't sleep. I can hear everything that that little ant was saying. Okay. I was up all night. I was crying by 3 a.m. So I know I had to go to school the next morning. Yeah, but my brother got it though. Use a paper clip to
Take it out?
yeah.
Paper clip?
Yeah.
Oh.
But anyway, I got my revenge though. I tortured the ant. Hey, I didn't. Its death was not fast. Okay, it suffered a long, painful death. That's my, that's my secret. But it suffered. I made it suffer. Okay, so here's conductive hearing loss. It's usually, again, caused by some obstruction. The obstruction can be mechanical, like wax, a lot of wax, or a bug, for instance. Or it could also be swelling, and inflammation, such as when you have an ear infection. Middle ear infections cause those structures to and the ear canal to swell, right? And therefore obstruct the opening and cause hearing loss. Sensory hearing loss is actual damage to the cochlea or the vestibulocochlear nerve. So this one is more serious because can we fix conductive hearing loss? Yes, you can take out the wax, you can take out the bug, you can treat the infection, swelling goes down, you can hear again. Sensory neural, can you fix it? No, this is involving damage to the nerves, right? So this is now irreparable. Okay, it's non-treatable. It's permanent hearing loss. But you can wear hearing aids that will enhance the whatever remaining hearing, the hearing sense you have. As already mentioned, there's mix. You can have both conductive and sensory neural hearing loss. Of course, what are manifestations? How do you know someone's deaf? What are the behavior of these patients? Okay, so here are some of your manifestations. So tinnitus, definitely subjective. So they'll report ringing in their ear. Okay, they'll ask you to, turn up the volume of the television or radio, phone, right? Some annoying things they do, right? They're on the subway, for instance, and the volume is on speaker, and then they're still screaming at that point. Can it destroy relationships?
Yeah.
Yes, because what will the behavior be of people who can't hear? Because they tend to just lip read, right? They just make sense of the movement of your mouth. And then they see, let's say I can't hear, and then John is there laughing like this, and then glancing at Miss Simon, and then Miss Simon is also giggling, right? Like that. So you're doing that, but I can't hear anything. So what do I tend to think?
They talk about you.
Yeah, you're laughing about me. Okay, I know what you're doing. You're talking about me, right? But anyway, yeah. So relationships get ruined, right? Because of these among spouses, friends, co-workers, right? So it's a big deal. Like you should hear my in-laws when they fight, the in-laws say, "Hey, what you doing with that pail? It's a pail. Oh, I thought it was a pail." Yeah, they can't hear each other. Yeah.
They're getting older.
They didn't say pail. It was a bucket. Yeah. What are you doing with that bucket? It's a bucket. I thought you said bucket.
Yeah. My grandma.
Prevention. If you know the cause, if we can identify the cause. So like I said, again, conductive hearing loss, most common cause is wax. It can occur in any age, not just elderly, can occur in little kids as well. Those who have small children, you notice what your kids put into their ears?
Objects, little blocks.
Yeah, it could be anything, right? They put stuff in there and then they have hearing loss, and then next thing you know, they have an infection because they stuck something in there. And that was from 2-3 weeks ago. The sensory neural, sometimes it's unavoidable because it's related to your job, and then let's say the industry does not provide a protection, for instance. So let's say who would be exposed to this, to really large noises? Okay, construction workers. Who else? Those who work at the gun range, right? What about those airline mechanics, okay, that work with large jet engines? Okay, our mowing workers, right? Garden, landscapers, right? They work with those loud blowers, leaf blowers, the mowing, yeah, the tractors. Okay, and then sometimes they just think, I'm okay with this. Don't wear ear protection, and then they grow old, then they have sensory neural hearing loss because of decades of noise exposure. Right, yeah, race car drivers or mechanics. So the whole pit crew, right, are exposed to these loud noises. Have you ever been to like a racing track? No, not on TV, like on live. Have you ever been there? It's loud, okay? One engine alone can, can be very loud. Imagine there's 36 cars there. They all revving up the engine at 7,000 RPM. It's really, really loud. Okay? Yes.
So like the headphones. Are the new headphones.
Oh yeah, the headphones, that's the same. That's why you have protection now. You have warnings on your phones, right? Telling you data about, hearing health. Yeah. It gives you data, right? Like how often have or how loud, how many decibels have your headphone use been? Okay, so it's part of the protection now. So here are risk factors. I've mentioned a few. So ear infections, that again is conductive hearing loss, etc. Let's go now to the interventions. What can we do? Well, depends on the cause. If it's repairable, let's say it's an infection and treat the infection, or if it requires surgery, then that will be surgery. We'll talk about surgical interventions later when we get to the actual disorders. For nursing management, what's the purpose of hearing? Why do we have the sense of hearing? What is it for? And so same as sight. So for safety, right? Yeah, safety and communication. Okay. Because most communication is not just written, right? It's also spoken, right? Okay. So here are our nursing care. So anyone with hearing loss, regardless if it's conductive or sensory neural, chart 59-5. Is this a good select all that apply question? All right. So this will apply, let's say the lighting. This will talk about the lighting. How should you approach the person? Should you or should you not use hand gestures to communicate? Okay. So here's always face the person. Make sure your face is well lit. Slowly, distinctively, do not shout. So most people with hearing loss learn to lip read. Okay, so make sure you're at least if you say you're concerned, the patient is on precaution, that makes it hard, right? Let's say they're on droplet or airborne precautions, you have to wear a mask. But otherwise, then you can pull down your mask, stay at a safe distance from the patient as you speak, so that way at least they can lip read, right? Or we have services in the hospital. We do have American Sign Language available. Each hospital facility is required by law, I mean Americans with Disabilities Act, ADA, to offer services for Americans with disabilities, and that includes hearing or vision impaired. Any questions on hearing loss? All right, that's it. Now let's go to only the topics that we cover. Serum infection, that's under PEDS, so I'll skip that. Foreign bodies also in PEDS as well as external otitis. Let's go to our first one is okay, let's start with motion sickness. Only because vertigo is here. So motion sickness is pretty much vertigo, right? Okay, so have you ever been dizzy and then there's your planet is spinning? Okay. So remember when you were playing, what is that game when you go around with a stick and then you do this and then you go around, it's a race, you put your forehead in the stick like this and you turn around like this about 10 times and then you go running again. You haven't played that?
I never played that.
Yeah, it's pretty fun.
Don't. Oh, usually, yeah. No, he's not talking about that.
No, it's not pinning the donkey. You didn't play that? Anyway, so it's gonna induce, okay, so it's gonna induce dizziness or vertigo. It's always accompanied with these, right? So when you have motion, who get seasick here?
Oh, no, I don't get sick. Oh, I do.
Oh yeah, I had a really bad case of it when I was younger. I'm better now, but I still don't go on. I'm okay with ships, the roller coasters. Yeah. So I have these manifestations: sweating, pallor, nausea, vomiting. All right, and then of course the spinning. Okay, so it's like I paid Disney $200.
Taking a test, I have all those, so what is it?
I don't know what you have. A test is not supposed to induce motion sickness or vertigo. Okay? Whatever you have,
You turn your head to
you
the left,
go
the whole room spinning. Turn to the right and spin it again.
over-the-counter treatments for motion sickness are you take like Dramamine, right? Or what is scopolamine? What else? Yeah, those patches also. Okay, so they're either dimenhydrinate or meclizine. Meclizine hydrochloride, they're all over the counter. They have instructions how many tablets to take and how long before the activity you're supposed to take it. Then we've got anticholinergic medications again. So I mentioned scopolamine patches. You wear that behind your ear. Again, about 1 to 2 hours before the activity or before your trip. Regardless though, any anticholinergics always have these unpleasant side effects. They get used, they cause dry mouth, dizziness, or drowsiness, and urinary retention, especially if it's taken by an older adult patient. Here's Meniere's. Anyone know anybody with Meniere's disease? Okay. So this is an unfortunate chronic incurable disease characterized by 3 symptoms. First is tinnitus. Second is vertigo. And third is sensorineural hearing loss. Let's not even talk about hearing loss. The vertigo itself, so because this is constant. So when you have these attacks, again, this is a chronic incurable disease. This is an inner ear disorder characterized by, again, these 3 symptoms. The patients have vertigo, ringing in the ears, and these are constant. And then the sensorineural hearing loss usually involves one ear, meaning they can still hear out of the other. But regardless, again, of despite the hearing loss, these 2 are the most debilitating. Would you agree? I mean, can you hold a job when you're having vertigo?
No.
Because remember, vertigo is not just the spinning. What always comes with that spinning? Nausea, vomiting, sweating, right? And the pallor, right? So, and then the vomiting would, of course, cause dehydration, poor health, because now you can't keep anything down, you can't eat, right? Treatment. Let's go straight to treatment. So how do we manage Meniere's disease? Again, is there a cure? No. Okay. So diet and medication is the key. Now, the diet is more for prevention of the disease. So later on, it's actually on this paragraph. So let's start with the diet. So most people benefit with a low sodium diet because they believe that Meniere's disease is caused by retention of increased fluid, endolymph, okay, and inner ear fluid, which increases pressure and then causes the symptoms. Okay, causes you to lose your balance and cause the spinning sensation because of the pressure on the vestibulo cochlear nerve. Okay, so you're limited to 1 to 1.5 milligrams per day or less. So sodium is the #1 restriction for the diet. Another is for medications. again, there's no drug to cure Meniere's. The medications are all symptomatic management, meaning if they have nausea, what do you give? Anti-nausea medications. If they have the dizziness, vertigo, what do you give? What was given earlier under motion sickness? Maclazine, dimenhydrinate. Okay, so anti-motion sickness medications. Right, that's basically it. Some people benefit, especially if the nausea is really, really bad. They'll have multiple types of antiemetics. We'll discuss them not here, but under cancer, because cancer patients have severe nausea vomiting as well. They have acute, delayed, and anticipated nausea, and that's under the cancer chapter. What was I gonna say? Oh, patients will benefit from sedatives. You know, benzodiazepines, Valium. Okay, so they can be given sedatives just to relax them. Because have you ever been nauseous when you're sleeping?
No.
I mean, how you have to be conscious in order to feel nausea, right? So therefore, does it make sense? You take a sedative, then you don't feel nausea, right?
Yeah.
But then again, can you do anything when you're sedated?
No. But that's like when a pregnant woman has morning sickness. Don't they give like
For severe cases, yes, but typically we control them with other medications. Plus, it's not really safe to be taking
because of the baby?
benzos, yeah. So stay hydrated, eat fresh fruits and vegetables. Again, watch your
So
sodium content. All right, so these are very good exam questions. Okay, so I'll give you select all that apply, which one to take, which ones to avoid. All right, your favorite. Okay. That includes alcohol as well. MSG also precipitates attacks. All right, and then avoid aspirin and aspirin-containing medications. What over-the-counter medications contain aspirin? No, I mean, because you're supposed to avoid them. Pepto contains aspirin. Motrin is ibuprofen. It's not aspirin. Yeah, duh. But there are some drugs that you're mixed with other medications over the counter that you're not aware. Oh, didn't know that has aspirin in it. Like I said again, so if really severe symptoms, the patient will be on benzodiazepines. Okay, we give them sedatives. Otherwise, it's all symptomatic, like I said. So meclizine for the vertigo, antiemetic agents. So you can choose from a variety of different emetics. Remember, the condition is is believed to be caused by increased pressure inside the middle ear, inner ear, caused by increase in endolymph. So diuretics can benefit these patients to help decrease the amount of fluid in there. And here are some of the surgical options. But just like glaucoma, did a lot of people benefit from surgery for glaucoma? No. So same thing here. Meniere's disease patients, some of them benefit from these surgical options, but not really. For surgery, let's look at the forgot which surgical procedure, because what did we use again for post-op care for people receiving eye surgery? Under what section was that again? Under cataract, right? Okay. For this one, we'll see on the next few pages. Because regardless of the surgical procedure done, is it a different ear? It's the same ear. So will the pre and post-op care be the same? Yes. Should they get the ear wet? So how do you shower? Okay, so you put a plug there. Okay, what else? Should you really get your hair wet?
No,
Okay. Can I bend over
no,
and wash my hair that way?
no.
Okay, because again, where is the ear located? Still the same head. So activities that increase intraocular and intracranial pressure, is it different for the intra-auditory pressure? The same. Okay. So can I sneeze? Should I be coughing? Should I be having sex? Should I be bending over to pick up something?
No,
Should I be pushing and giving birth to a big turd?
no.
Okay, all right. So you know the prohibited activities, right? You still remember there was a chart last week? Okay, so follow those same things. Antihistamines. Yeah. For coughing, we can give lidocaine to numb to numb the throat. Okay, so we can do that. Say, yeah, so we give antihistamines. So that is applicable for people who have craniotomies. So we routinely do that because we know sneezing or coughing after brain surgery, is that good? Okay, that can be disastrous. So here's your nursing care plans, okay, for what to do with patients with vertigo. Again, this will always be accompanied by what symptoms again? Nausea, vomiting, drowsiness, pallor. Okay. Alright. I think this surgery, no, it's not. Okay. Just looking for the pre and post-op care. Just a warning on hearing aids. Every admitted patient, we always check for possessions, right? Belongings on admission. What do you have on you? So we take a look at how much cash they have, how many credit cards, what are they? We count them. Everything's accounted for. That includes eyeglasses, hearing aids, and dentures. The last two are the most expensive. Hearing aids cost upwards of $1,500 to $3,000, depending on the type that they use. Are they big or small?
No.
Tiny things. Can they leave them on the food tray and then here comes the dietary people getting rid of them and then there goes the hearing aid, $3,000. Okay. Very important that you take note of what was brought on admission. And then again, very clerical job or task. You have to have the patient sign the belonging sheet. So we put all their belongings in the computer on Epic, we print it, and we have the patient sign acknowledging what did they have when they came in. Yeah, is that understood? If they're unable to do that on admission, meaning they're still, tired, groggy, at some point it has to be signed. All right. And it will not disappear on your work list. It will keep appearing there until someone addresses it. Are we clear? Because your tasks are supposed to turn green at the end of each shift. They will stay red or yellow depending on how long it's been there until you complete it. You understand? Okay, is it important? Yes, because can the patient claim that they lost their hearing aid if they never signed or acknowledged the list? Yes, and then who's going to pay for it? The hospital. And where do you think the hospital will take the money from? well, not your paycheck, but your your future raises. Okay, so that will affect, the business, hospital can't stay in business, then they can't pay you more. Right? And all they'll say is, forced to close. Okay, we lost 24 hearing aids last week alone. Right? We had to pay for them. Do you understand? All right, so you should care. Okay? That's your raise right there. Hospital can't give you raises unless they make money. And these are how we lose money, okay? When we lose patients' belongings. Did I tell you a story about the dentures that my CNA lost? Okay, anyway, so he cleaned them, right? He's a very good guy. He's a nurse now. He's an RN now. But back then he was a CNA. So he cleaned the patient's dentures. I don't know what possessed him. He put it on top of the sharps box. It was clean, he meant to put it on top and then get a container and then grab it and put it into the container. I don't know why he just didn't put it on the table, on the bedside table. Anyway, so I saw him with his hand inside the sharps box. Okay, and I said, "What are you doing? Come out here." And then he was sweating, pale, and says, "Man, I messed up, man. I dropped the patient's dentures in the sharps box." I said, "Okay, we can figure this out." So we grabbed the sharps box, and then I had to open a surgical kit because I was looking for a long forceps. Okay, so that's what we use. So we fished it out because you can't break it. Okay, it's dangerous. Plus if you break it, somebody knows, it's a dangerous thing. So that's what we did. Okay, we were able to fish it out, right? And to this day, we still on social media. He never forgets, and he says, he's my brother for life because
Yo.
of the dentures.
Did you put back into the patient mouth?
Of course, we cleaned it.
They got the glue and put it right in your mouth.
Okay, I'm still looking for the surgery. And that would be because it's on the blueprint. Can't find it. All right, it's on post-op care for ear surgery is on page 1951, chart 59-7. It's under middle or mastoid surgery. So no blowing your nose after 2 to 3 weeks after surgery. Sneeze and cough with the mouth open. How do you sneeze or cough with your mouth open? With your mouth open. Achoo! Okay? Keep it open because what will happen if you're doing it closed? So the pressure will go out through your ears. Okay, that's the only other opening if you close your mouth and and what happens again if you keep the mouth closed? Again, intracranial pressure, intraocular, and auditory pressure will also increase. So same, if you look at it and compare it to the post-eye surgery, activity restrictions are identical. Okay, again, it's the same head. The ears and the eyes are in the same head. Is this reportable? What does it say? They're normal. So are they reportable? Okay. Okay. So they lose their hearing. Is that normal? Okay. Temporary hearing loss is normal in the operative ear. Again, caused by the swelling, fluid, or blood buildup in that surgical ear. Report. This one you report. Right? So we mentioned this earlier. Do not get the operative ear wet for how long? 2 weeks after. But they need to wash their hair. So how do they do it again? Like this over the sink? Okay, so you can saturate a cotton ball with petroleum jelly. Why petroleum jelly? Is this impermeable to water? Can water pass through wax? No. Okay, so that's your protection. Okay, that's a water insoluble substance, so it keeps your ear dry. And loosely packing it into the ear. All right. Any questions? So where's this again? Page 1951. Just make sure. I think we're done. That's it. We've done Meniere's, right? We did tinnitus and vertigo. And we did ear surgery. And we did hearing loss. Anything else I missed on the blueprint? Let me make sure. Oh, administration of eardrops. Okay, thank you. Ear irrigation. And surgery of state protective. That's okay. We already showed it under mastectomy, so it'll be the same.
You go from the blueprint? Yeah. So everything on that blueprint will be the same? Well, the questions is like different.
Yeah.
But it's like the concepts, right?
Yeah, we'll do that after the ears.
I think that's the last one.
Again, for eardrop administration, there is no chart.
But there's a video. On page 1949, right, Espresso?
Okay, so here's the video. So like Miss Diallo said, it's on page 1949, and I'll grab the question from this video. It's a demonstration on how to position the head, what to do after eardrop administration, what's the temperature of the bottle. Okay, should it be cold, room temperature? Should it be warm? What is the patient instructed to do after eardrop administration? And what do you put in the ear after administration of the drops? All right, it's all going to be described in the video. Any question?
The video don't work.
It works for me.
Probably gonna work on the app.
So what are we going to be doing next?
I'll be instilling eardrops into a patient who has an ear infection.
Okay,
And your date of birth?
October
21st.
See, what position did the patient go in? Is it on or opposite of the? Uh-oh, sorry, that was wrong button. Anyway, please watch the video. I'll grab the questions from there. All right.
Okay, that's a thank you.
It was